is the lecture over Alzheimer's disease. So what is happening in the body with Alzheimer's disease? First, we're going to clarify 3 different type terms: delirium, dementia, and Alzheimer's disease. So delirium is characterized by a disturbance of consciousness and a change in cognition that develop over a short period. Dementia is a general term for progressive loss of brain function and impaired cognition. There's deterioration of cognitive functioning and global impairment of intellect with no change in consciousness. There's 2 different types of dementia: vascular dementia, which results from strokes or other vascular disorders that decrease blood flow to parts of the brain, and then Alzheimer's disease is the most common type of dementia that affects people older than 65 years. It's marked by impaired memory and thinking skills. So in Alzheimer's dementia, the neurofibrillary tangles are bundles of filaments inside the neuron that abnormally twist around each other and block the neurons and disrupt signals. There's also a degeneration of the cholinergic neuron and deficiency in ACH, which is acetylcholine. And then beta amyloid protein plaques contribute to neuronal injury as well. If you'll refer to your table on page 883, it's table 36.1, there's a comparison of the 2 major types of dementia. So in your assessment findings, pay attention to the blue vocabulary that can be found in your book on page 885. There's early stage dementia, moderate stage Alzheimer's disease, and late stage Alzheimer's disease, which is severe. In early stage, patients will be independent in ADLs, and they may deny even the presence of symptoms, but they'll forget some names, misplace household items, have short-term memory loss, and difficulty recalling new information. And they'll show subtle changes in personality or behavior. Loss of initiative and less engaged in social relationships, and mild impaired cognition and problems in judgment will be noted, and then demonstrate decreased performance, especially when stressed. They're unable to travel alone to new destinations, and they often have a decreased sense of smell. In moderate stage, they have impairment of all cognitive functions. They demonstrate problems with handling or are unable to handle money and finances. They're disoriented to time, place, and event, and possibly depressed or agitated. They become increasingly dependent in their ADLs, have visuospatial deficits, and so they'll have difficulty driving and get lost. Speech and language deficits will be noted. They'll be less talkative, have decreased use of vocabulary, increasingly non-fluent, and eventually aphasic. So paying attention, aphasic is your blue vocabulary, which problems with speech, which is your expressive aphasia, or language, which is your receptive aphasia. They may be incontinent of urine and stool and have psychotic behavior such as delusions, hallucinations, and paranoia. They'll wander or have episodes of wandering and then trouble sleeping. In the late stage, they're completely incapacitated, bedridden, and totally dependent in their ADLs. They have a loss of mobility and verbal skills, and possibly will demonstrate seizures and tremors. And then they have agnosia. Agnosia is that loss of sensory comprehension and ability to recognize familiar sensory stimulation, including facial recognition. For labs and tests, their diagnosis is made based on clinical history, presentation, and imaging assessment. An amyloid PET scan can be used. This is a radioactive tracer. It'll highlight amyloid protein in the brain, and a high amount of amyloid protein indicates a high risk of disease. An MRI will be done to rule out other causes, and then genetic testing is available as well. With genetic testing, one of the tests is the apolipoprotein E4, or APOE-E4. This is a protein that transports cholesterol, and then it indicates the increased risk of developing the disease. Amyloid beta protein precursor soluble, so SBPP, may be measured to diagnose Alzheimer's disease as well. And then other genes that cause familial Alzheimer's disease are also available. Our nursing interventions and treatments for our anticipated hypothesis would be decreased memory and cognition due to neuronal changes in the brain. And our desired outcome in the early stage is to have the client maintain the ability to perform basic mental processes. And as Alzheimer's disease progresses, clients cannot meet this outcome, so therefore the desired outcome is to maintain memory and cognition for as long as possible to keep patients safe and increase their quality of life. So this can be achieved through non-pharmacologic means and through some pharmacologic interventions. So collaboration with nursing teamwork, interprofessional collaboration, and client and patient teaching. So some of the non-pharmacologic things we can do is cognitive stimulation and memory training, structuring the environment, orientation or validation training, promoting self-management, and promoting bowel and bladder continence. So with cognitive stimulation and memory training, this is used to reinforce or promote desired outcome and facilitate memory. You can use videos and pictures of family members to reminisce with the patient about pleasant experiences in the past. Refer the client to personal items in the room and help the client begin to talk about their meaning in the present and past. Structuring the environment, you want to keep the environment free from distractions and the noise decreased to a minimum. Establish a routine and follow it as much as possible. This is the best benefit for them. With your action alert on page 888, Alzheimer's disease patients in a new setting or environment, you want to collaborate with that staff and admitting department to select a room in the quietest area of the unit, away from obvious exits. You don't want them to wander and get on the stairwell or get on the elevators. A private room may be needed if patient has a history of the agitation or wandering. And then keep the TV off, so keep that noise to a minimum unless the patient requests it to be turned on or if they turn it on themselves. So we want to orientate or have validation training. So ways to orient is just have clocks and single date calendars to help maintain orientation early in the disease. And then teach the family to frequently orient the client with a date, time, where they are, who they are. But remember, this is only early in the disease. In the late disease, validation therapy is the best, as orientation training leads to agitation. So in validation therapy, you just recognize and acknowledge the client's feelings and concerns. Promoting self-management. We want to encourage the client to perform as much self-care as possible to maintain independence. And then to promote bowel and bladder continence, we want to offer toileting every 2 hours. Maintain adequate fluid intake, and making sure they're drinking enough. And then use frequent surveillance to prevent any falls. And then with promoting in communication, on box 36.2 on page 889 in your book. So things to do is like ask simple direct questions that require only a yes or no answer that the patient can communicate. Give them time to communicate that as well, to answer yes or no. You want to provide instructions with pictures in a place that patients will see if they can read them. Use simple and short sentences and one-step instructions, so one step at a time. Use gestures to help the patient understand and validate the patient's feelings as needed. Limit choices. Too many choices cause frustration and increase confusion, and never assume that the patient is totally confused and can't understand what's being communicated. You also want to try to anticipate the patient's needs and interpret nonverbal communication. And then use distraction by attracting the patient's attention to promote communication and maintain safety. Some pharmacologic treatment that is given. Right now there's no available drugs that can cure or slow the progression of Alzheimer's disease, but a few drugs may improve the symptoms associated with the disease in some patients. So there's ACH cholinergic inhibitors. These improve cholinergic neurotransmission in the brain by delaying the destruction of acetylcholine by the enzyme cholinesterase. So these are donepezil and galantamine. With these medications, you do want to monitor for GI upset, so making sure they take these medications with food. Monitor for any muscle spasms, bradycardia, so check for their pulse. They're at an increased risk for falls as well. The next drug is NMDA antagonist, and this drug blocks excess amounts of glutamate that can damage nerve cells, and this one is amantine. SSRIs manage the depression and may improve cognitive function, so citalopram, paroxetine, and then anti-anxiety medications such as lorazepam. Now, in 2022, the U.S. Food and Drug Administration gave fast-track approval for aducanumab, the first new drug for Alzheimer's disease in the past 20 years. It's an amyloid beta-directed monoclonal antibody, and is proposed to treat Alzheimer's disease by reducing amyloid plaques, which we said could be a possible, or is like an indication. This is used best in the early stages of Alzheimer's dementia, and they'll get an infusion every 4 weeks. So some risk factors. So your non-modifiable risk factors for Alzheimer's disease is patients that are older than 65, women are more at risk than men, and then genetics do play a part. Black individuals are twice the risk compared with whites, and Hispanic are 1.5 times higher risk as well. And then if someone has the presence of one or more forms of the E4 protein, they're at higher risk. Clients need to be aware of modifiable factors, such as traumatic brain injury. On page 888, it talks about veteran health under your patient-centered care. Veterans who have experienced traumatic brain injury and those with post-traumatic stress disorder are more likely to develop dementia. And then they've also found like high levels of the tau protein accumulation in the brains of many veterans makes them at high risk for early onset Alzheimer's disease. Cardiovascular disease is a modifiable factor. Smoking, depression. Down syndrome should be under non-modifiable. I don't know how Down syndrome is modifiable, but Down syndrome is also a risk factor for Alzheimer's disease. And then social determinants of health. So your lower socioeconomic status, low education level, performance in manual labor jobs, lack of food security, decreased social interaction or social isolation, increased stress, and lack of access to health care all play a role in social determinants of health and can increase their risk of Alzheimer's disease. So for complications, safety is a concern as the disease progresses. So box 36.3, page 890, these are approaches to prevent and manage wandering in hospitalized patients, such as identifying those at risk, appropriate supervision, frequently checking on them, placing them in an area that provides maximum observation, just not at a nurse's station. Use family members, friends, volunteers, and sitters to sit with a patient and help watch them. Keep them away from elevators and stairs. Don't change rooms frequently because that can increase their confusion. Avoid physical and chemical restraints if possible. Assess and treat their pain. Keep them reoriented in validation therapy. Frequent toileting, bed, chair alarms. Prevent that overstimulation, so excessive noise. And then if they can tolerate it, maybe some soft music and non-glare lighting if possible. Other complications could be the risk for aspiration pneumonia. We'll go into more detail when we talk about Parkinson's disease, so if you can refer to that handout. Dehydration and malnutrition. So for patient teaching and management and prevention of Alzheimer's disease, box 36.4 on page 891 says reducing family informal caregiver stress. So you want to take care of the family members also so that they can adequately take care of their family member. So to do this, we want to maintain realistic expectations. Tell them to take one day at a time. Find positive aspects in any situation or incident. Try to use humor. There's resources out there available for them, and they can contact the Alzheimer's Association to find those resources. Explore alternate care settings. There may come a time when their family's not able to take care of their family member, may have to place them in like long-term care or assisted living. Establish advanced directives. Take time away from the patient for rest and relaxation each day. They need time away just to maintain their self-care. And then they also need to seek longer periods of time away. So not just like an hour, maybe they need to get out of the house and have someone watch their family member. They need to take care of themselves with diet, exercise, and rest. And then just remind them to be realistic in what they can and can't do, and accept help. Let others come in and help them. They can use relaxation techniques like meditation, massage to help also with their wellness. And then seek out clergy or spiritual counselor if needed. For managing the behaviors for the patients with Alzheimer's disease at home, they're going to evaluate the patient's environment to ensure safety. We want to maintain a safe environment so to decrease their risk of falls or harm if they are at that agitated or wandering stage. Help them with those with mild stage disease remain oriented to the extent possible. Communicate with the patient based on their ability to understand. Encourage their independence with ADLs as much as possible. Don't rush them. Let them do it. May take them a while, but that's okay. When a problem behavior occurs, direct the patient to another activity. So try to distract them and change their viewpoint. Minimize excessive stimulation. They may get overstimulated and may cause more agitation. And then they can also register the patient with the Alzheimer's Association as well. And that concludes this lecture. Thank you.